I wanted to talk to you all about COVID-19 from a primary care outpatient perspective. You have a handout that is associated with this talk that I think will be useful. I think it's also important to note that it is the beginning of April of 2020, and this is obviously something that is rapidly changing and we're learning new things. So it's important for you to know the date that this video was made. Starting with transmission, obviously respiratory droplets are the single most important means of transmission. It's why we tell people that it's so important to cover their mouth and to do a really good job covering their mouth, especially when they're coughing and sneezing. It's why we ask people to be 6 feet away, etc. And the other piece that is important regarding this is masks. And for our patients to generate some sort of homemade mask when they go out in public, when they go to the grocery store, when they go to the bike path to take a walk or to walk around a pond, and they're keeping their 6 feet distance, it's still important that they should be wearing a mask in order to flatten the curve. Also important, but not quite as important as respiratory droplets, are surfaces. And it's why, of course, that we need to do a good job washing our hands regularly and not touching our face. Airborne transmission is a little controversial. It's pretty unlikely. It certainly becomes a possibility when you think about medical procedures that involve aerosolizing, like extubating a patient. And in that case, from a healthcare worker point of view, that's where an N95 mask or proper protective equipment becomes more important. There's another issue about vertical transmission, and that has only been studied in a very small study in China, and in that study there was no vertical transmission. From an onset point of view, you all know that incubation period is 2 to 14 days with an average of about 5 days. And you know, the trajectory is when you get your first symptoms, it takes about 5 days before most people are starting to get short of breath and a viral pneumonia picture. And about 10 days out is often when people will, if they are going to go into respiratory failure, they will enter respiratory failure at about the 10-day point, typically an ARDS picture, and it's typically a result of this cytokine storm. Of course, there's so much variability with this onset, but those are the averages and those are the typical patterns that people are seeing. This cytokine storm that people are talking about generates multi-organ failure and often can happen in a matter of hours. If people are fortunate enough to be extubated after they're intubated, it's typically about 10 days after intubation. So it's a long haul being intubated. From a testing point of view, currently we're not ready for antibody testing yet. We hope in the near future that will be ready. Right now, PCR testing is what's being used, and I'm hearing about 70% sensitivity. So the bad news of that is 30% false negatives, which you don't hear people talking about, but that's pretty significant. And that sensitivity will actually go down early in the disease before people are symptomatic, or if they've just been symptomatic for a day or two. That sensitivity will even go less than 70%, or if there's poor technique with the testing, that sensitivity can go down. Interestingly, CT scans seem to be more sensitive than the PCR test. Reading the images of the CT scan, I'm not suggesting that we use CT scans as a screening tool, but it's just interesting to know that. At this moment, testing is being prioritized for healthcare workers and patients who are sick enough to be hospitalized. I think very soon we should be expanding testing pretty dramatically to a much larger population. The prognosis for COVID-19, about 80% of people will get no symptoms or very self-limited symptoms and get better pretty quickly. About 15% which is a pretty high percentage, will get sick enough to need to be hospitalized, and about 5% of people who get infected are sick enough to be in an ICU and require a ventilator. And if you do get a ventilator, I'm hearing that about 80% mortality rate once you get to that point of ventilator. In terms of mortality, it's being quoted all over the map. I think it's probably going to be settling out at about a 1% mortality rate, or maybe a little bit lower once we know all the people that are infected and the denominator settles out. Clinical manifestations also are very variable, and we're seeing about 90% of people getting fever, but maybe only half of those who are experiencing fever at the onset of their symptoms. Most people are experiencing fatigue and malaise, and that's at about 70%, about 60% with a dry cough, some of which are producing sputum, but for most people, that's a dry cough. About 40% are experiencing a decreased appetite, some of whom are experiencing a loss of smell and taste with that decreased appetite, which is a very interesting aspect of COVID-19. About a third of people are experiencing muscle aches and shortness of breath. And what's so interesting about COVID-19 is the silent hypoxemia that is so common, where people's distress around shortness of breath is there, but not dramatic, but the pulse ox lowering is much more dramatic. We're seeing GI symptoms that are much less common, but can indicate more severe disease, some nausea without vomiting, some belly discomfort with some loose bowel movements. But really the hallmark of this virus, which is so fascinating, is the hypoxemia with less than you would expect dyspnea and shortness of breath, which is why we might start doing some home monitoring by giving patients inexpensive pulse ox machines to take home with them moving forward. When you think about influenza compared with COVID-19, influenza is a much more rapid onset. There's typically more fever or higher fevers and body aches with influenza, typically more congestion and more nausea, vomiting, diarrhea with influenza, but less cough and less shortness of breath in people with the flu or influenza. Another interesting difference between influenza and COVID-19 is people with influenza are prone to getting a secondary bacterial pneumonia, whereas that complication is very uncommon with COVID-19. Influenza typically has a much shorter incubation period than COVID-19, with only 1 to 4 days. And influenza is much more likely to affect children, whereas COVID-19 doesn't seem to be affecting children very much at all. When you think about risk factors for severe disease and mortality with COVID-19, some of the big risk factors are smoking. It's a great time to work with patients on smoking cessation. I think there's more motivation than there has been perhaps ever to do that. There's also motivation to get younger. That's a harder counseling to do. Folks who are over than 55 years old are at higher risk, and diabetes, hypertension, kidney disease, pre-existing heart and lung disease such as asthma, COPD, congestive heart failure, and anything that can cause immunosuppression like chemotherapy, steroid use, transplant, all increase people's risk. And so when you think about an overall mortality, we talked about settling out around 1%, pretty rare in children, as we talked about. And then if you look at by decade, folks who are less than 50, it looks like about a 0.5% mortality rate. And then in your 50s, about 2%, 60s, 4%, 70s, 8%, 80s, 16% is what is being quoted at this time. When you think about treatment for COVID-19, some important concepts to keep in mind. It would be ideal to avoid steroids if possible in a patient with COVID-19. Ibuprofen has been a little bit controversial. There has not been clear evidence guiding us around NSAID use, although people are really trying to use acetaminophen, Tylenol instead of NSAIDs. Ibuprofen may in fact increase the severity and the duration of a COVID-19 infection. There's also talk about the use of ACE inhibitors and angiotensin receptor blockers, ARBs. The thing about those two classes of medications is they're very common, obviously used for hypertension, and they could potentially make COVID-19 infection worse or better. It's unclear. In terms of pathophysiology, COVID-19 seems to be binding to ACE receptors. So what happens is with use of an ACE inhibitor or an ARB, there's going to be upregulation of those receptors, which could make the infection worse. On the other hand, ACE inhibitors and ARBs may protect against lung disease. So this one could go either direction, and we're waiting on more evidence to guide us there. But the long and short of it is if somebody's on an ACE inhibitor or an ARB and gets a COVID-19 infection, we are not recommending for people to stop that medication. Of course, you've heard about hydroxychloroquine, which is better than chloroquine and may decrease severe progression of disease in COVID-19 by preventing that cytokine storm. The jury is still out. There are a lot of trials with this, so we should be hearing more about that soon. There's some antiviral agents like remdesivir, which may hold some promise and worked well with MERS. Convalescent plasma may be helpful. Interesting report about statins potentially being helpful by lowering the incidence of severe viral pneumonias and, of course, decreasing cardiac complications. And statins may also have a role in increasing the immune response in viral infections. That's some anecdotal stuff, but certainly if a patient got a COVID-19 infection, was on a statin, we would encourage them to stay on the statin. There may be some benefit. From a laboratory point of view, some of the more common labs we're seeing go up are C-reactive protein, CRP, ferritin, and liver enzymes, AST, ALT. And we're seeing leukopenia and thrombocytopenia, mild leukopenia and thrombocytopenia with COVID-19 infection as well. So what is the primary care role with COVID-19 infections? It's actually quite critical. One of the things we're doing is certainly triaging any patients with respiratory symptoms, including asthma and COPD, and helping them stay healthy and helping keep them out of the emergency department and the hospital unless appropriate. The other thing is that acute and chronic disease have not decided to leave us, all other acute and chronic diseases, just because we're in the midst of a pandemic. So we really have an important role to manage the health of our patients and keep our patients healthy with all of the acute and chronic disease that they're experiencing right now. And again, to keep them out of emergency departments and hospitals and keeping them as healthy as possible, teaching them how to maximize their immune system by walking more, sleeping more, eating healthier foods, kind of leaning plant-based and avoiding sugar. And I think a lot of patients have become really motivated and have some more opportunity now to walk more than they've been walking, exercise more than they've been exercising, sleep more than they've been sleeping, prepare what they're eating, and eat more home-cooked food. And I think what we're seeing in a lot of patients is what I like to call the COVID-15. The opposite of the freshman 15, where you gain 15 pounds, the COVID-15 is we're seeing a lot of patients who are losing weight because of these opportunities for wellness. And we can certainly encourage our patients to take advantage of some of these opportunities and prepare their bodies and crank up their immune systems so that if they happen to encounter COVID-19, they're ready as the healthiest version of themselves. I hope this was helpful for you all. We'll certainly need to have some updates, and let's keep on working hard to keep our patients as healthy as possible.